Hello everybody, I am Dr. Yasin. Today I will be talking regarding the topic foot examination, identifying early signs of neuropathy and ulcer. So half of your patients who would come to you might complain of diabetic foot issues like neuropathy, and the prevalence of neuropathy increases with increase in blood sugar levels and poor glycemic control. So when you look at the different types, most of the patients that come to you, they will be having peripheral neuropathy. So that is what they will complain of: numbness, tingling sensation, paresthesia in the foot, in the leg, and sometimes in the hands and the upper limb. And some of the patients, they come to you, you will see that their heart rate is irregular, blood pressure is irregular, there might be some GI issues, bladder issues. Some patients complain of sexual dysfunction. And some patients just might come and tell you they have erectile dysfunction. So that's a sign where it shows that these patients are having autonomic neuropathy issues. And then there are focal and proximal neuropathy. That's not very common, but still it's there. And when you look into the problems, how it happens is that we know that increase in blood sugar levels can increase the oxidative stress, and then there is inflammation. And the main component here is the microvascular damage. And because of the ischemia, the neural nerve fibers are getting hypoxia, and that's the main reason for the damage. Also, looking into one of the other problems, when there is sympathetic denervation, normally we have an AV shunt in the periphery, and it tends to be always in a closed situation. But when the denervation takes place in diabetic neuropathy, the shunt opens up and the peripheral circulation is bypassed. This causes, in certain patients like this, you will see that they will have dryness of the skin, and you will find some cutaneous edema. Next, there is a motor neuropathy. In motor neuropathy, what happens is there is muscular dystrophy, and especially in the foot, there is now irregularity between the flexors and the extensors of the foot, and this causes some amount of deformities to take place in the foot. And in these patients you will see claw toes, mallet toes, and hammer toes. So what happens with these deformities is that the pressure point is now redistributed. Normally the pressure point is even throughout the foot, so now it becomes concentrated into one point. See, this is an example where you can see the metatarsal fat pad migrates forward when the patient develops a hammer toe, and the base of the metatarsal head now becomes a high pressure point. This is where now this patient can develop a diabetic foot ulcer or a callus formation. So a combination of neuropathy, vascular issue, and the deformity is the core reason for diabetic foot. And sometimes it is mostly neuropathic, or sometimes it's mostly vascular, but most of the time it's a combination of both. So in general examination, when the patient comes to you, you have to examine the patient from head to toe. And when you look at the foot, you see that the skin is dry, it has cracks. I think so you can see the image here. The skin looks very dry, cracky, and there is loss of hair in the leg. And that's a sign which shows that there is autonomic neuropathy and peripheral neuropathy. And then you have to look for any calluses, corns, changes in their nails, any deformities like bunions, hammer toes, and go for a sensory motor evaluation. The basic thing we all should be doing is a monofilament test. You should have a monofilament in your clinic, and we prick the plantar aspect of the foot and see for the sensation there. We check for vibration test, we check for pinprick test, temperature sensation, and the motor functions, we assess the muscular strength and the reflexes. Then you do a palpitation, you palpate the blood vessels, and the posterior tibial artery and the dorsalis pedis artery are the main vessels that we are going to palpate for. We see how the condition of the blood vessel is. We can even use something called arterial Doppler. This is a small handheld arterial Doppler. Rather than just the feel, it gives you a little bit more. It gives you an image of the bay formation. It gives you a sound feedback, how the blood is flowing through the vessel. And it's a very small device and a very cheap device. So it's just like having a stethoscope in your clinic. It's a good thing to have with you when you assess your patient. And sometimes you get lucky and you get to diagnose patients with peripheral arterial diseases, and a lot of patients are underdiagnosed. So this is where screening is useful to pick up these cases. And you palpate the leg and see, and the patient is having any cuts, bruises, blisters, and the patient is probably not aware of. Some patients might have intertrigo. And the gold standard is the ankle brachial index. So doing an ankle brachial index is a very useful tool. It can be manually done, and there are some machines that are now available which can help do ankle brachial index much faster and easier for you. So the general rule is that 1 to 1.5 is normal, and when it goes very low beyond 0.8, 0.5, you want to suspect vascular issues in the patient and do further follow-up. Other examinations are biostachiometry, toe brachial index, pedovarography. That's the image there. It shows how the pressure is distributed in the foot, and then you can do a ultrasound and exercise ABI. And if needed, the patient might be sent for MRI or CT angiogram if you suspect there is a vascular issue with the patient. The management part, the first things first is correct the blood sugar levels, the BP, the hypercholesterolemia, advise the patient to stop smoking and not use alcohol, regular exercise. Medications like methylcobalamin in strengths of 500, 1,000, 1,500 are available. You can start them on those in the beginning, because some patients who are extensively using metformin will have deficiency of that. So that's the first thing you want to do. Then there is pregabalin, gabapentin, and some other medications like fluoxetine, amitriptyline, nortriptyline. And if needed, the patient might be, if you feel that it's needed, the patient should be sent for revascularization procedures. Some patients do need revascularization, like bypass or angioplasty of the arteries of the lower limb. So some patients, they come to you and say they have this feeling of that there is a rock or a stone inside the foot, and they're actually saying partially a true factor, because a callus is like a stone in your shoe, and the callus should be always removed. So removal of callus is a simple procedure. You have to do it in an aseptic procedure. It's an outpatient procedure, and we can use 24 surgical blade to scrape off the callus, and that's the most effective and easiest way to do it. And proper diabetic footwear is a must for all diabetic patients. And if some patients, if they have some deformity, rather than going and correcting the deformity, it is better to adapt a footwear to their deformity. So that's the best thing you want to do. So you have to tell them to have a specified custom footwear to help with their foot deformity. And to conclude, I would just like to say, always examine your patient head to toe. Diabetic foot issues and neuropathic issues are of high suspicion in your patients. You should always suspect that and go for examining those things. Whatever screening modality is available for you, you should use it. Whatever screening modality your patients can afford, you should use it. The best technology available now is the best technology. Diabetic footwear is a must. Proper care for diabetic foot can make a lot of difference, because once the patient develops an ulcer and might go into an amputation, the quality of life and the life expectancy reduces drastically. So prevention is better than cure. So thank you very much. Happy foot is happy life. Thank you.